Come on behind us. Come this way.
Well, I like how the glasses and stuff are clinking.
Yes. All right. Good morning, USCA. Are you guys ready for our last day? My name is Jessica Raymond, and I've had the honor of serving as your host committee chair for 2018.
Hello, everyone. My name is Nicole Elenoff, and I've had the honor to serve as your 2018 host committee co-chair.
Today we have the privilege of passing the torch to the chairs of the DC Host Committee. But before that happens, we would like to recognize our entire host committee for volunteering their time, resources, and efforts to make the 22nd United States Conference on AIDS a success.
Will all the members of our host committee in the room please stand? We've had approximately 140 host committee members and over 100 volunteers. No matter how you have supported, we deeply appreciate your commitment to the cause.
Nicole and I are very proud of this conference and the turnout. However, we are most proud of the fact that you all had a great time in our city and our home, and that our team pulled together to show the nation what Orlando can do.
With all that being said, Jessica and I have learned a few things over the last year, and we'd like to share.
Be patient, flexible, understanding, and kind.
Trust the process.
Encourage your team during the process.
Start fundraising now, like yesterday, like last year. Okay. Do your best to assemble a diverse team.
More glitter, less shade. So for those of you in the room who don't know what that means, we should spend more time celebrating each other instead of tearing each other down. That was a principle of our host committee.
Don't be afraid to look for support in unlikely places. Let's expand the narrative and get more people involved in fighting our epidemic.
Lead with intentionality as the chairs.
Listen to your community.
Build up-and-coming communities and encourage intergenerational relationships.
Celebrate differences and intersectionality.
And most importantly, and our last piece of advice to you guys, when you feel like quitting, because it will happen, remember why you do this work in the first place and keep going. You're resilient.
At this point in time, we pass the torch to the DC Host Committee. That will be the home for USCA in 2019, and we wish you nothing but the best.
Good morning, USCA. My name is Michael Carfin, and I'm with the DC Department of Health. And I first want to congratulate and thank the host committee from Orlando. They did an incredible, fantastic job. Thank you. And of course, to the team at NMAC and all of the sponsors of the conference, it's been a moving, inspiring, motivating, and memorable conference. So we welcome you back to DC in 2019. I want to say first that we are some of the real Washington, D.C. We're going to confuse you with some of the people who are on some month-to-month leases. that will be expiring in 2 years. We are the Washington, D.C. of open minds and open hearts who are committed and passionate to social change, about health and well-being, and about sex. So we see you. We see you, and everyone is welcome. Todos son bienvenidos. So one more piece of recommendation, encouragement. The 700,000 residents of Washington, D.C. do not have a vote in our nation's elections and politics. So we encourage you to vote so that next year in Washington, D.C., we bring the fight back to our nation's capital. So we will see you next year. Thank you.
Give it up for our host committees. Good morning. Good morning. Thank you. Thank you. Good morning. My name is Jesse Milan. I'm the president and CEO at AIDS United. Thank you. You know, in my faith tradition, on a Sunday morning, we give thanks for our blessings. We remember those in need, and we honor our dead. And we're going to do that a couple of times this morning. And we're going to start by recognizing that 1 year ago today, AIDS United and our partners at INMAC and Gilead announced our Hurricane Relief Fund. And over the past year, we have raised and distributed $2 million to those impacted by Irma, Maria, and Harvey. So this morning, if you are here from Puerto Rico, stand up. If you're here from Houston, stand up. From Greater Houston, from South Florida, from the Virgin Islands, stand up. We stand with you. Thank you. Thank you. And we remember all those from the HIV community in those places who lost their homes and all their belongings. And we especially remember the nearly 5,000 who died. Let's remember them now. Thank you. Thank you. So we saved for last one of the most important conversations for us in the HIV community. That's the impact of the opioid crisis on our community. We have known for decades that harm reduction works, haven't we? But you wouldn't know that by talking to too many lawmakers, and you wouldn't know that by what you're seeing in the media. What you see in the media is this: Scott County, Indiana, rural Vermont. And these are big stories because these populations did not historically have drug overdose and injection drug use and HIV/AIDS in their communities. And so they are big stories. But are they the whole story? I don't think so, and you know that, because injection drug use and drug overdose has impacted urban centers and our community for decades. We're the bigger story. And we dare not let the media and lawmakers focus only on these. And why are they doing so? Because these are rural, white populations. That is not us. And we know that we have a problem in our own backyards. AIDS activists know that if we do not work hard to get some of those billions of dollars Congress is talking about, our people will be left behind, they'll be in need, and they won't get the recovery that they need. AIDS activists know this work. We are the experts. We're the experts. We've been doing needle exchange legally and with underground services for years. We've been doing, and now we're doing, safer consumption sites, right? We're going to figure it out. We're the experts. I'm proud to say that Philadelphia, where I was AIDS director, was one of the first to use city taxpayer dollars to actually support needle exchange services. Give it up for Philly. And the proof of our success is in the numbers themselves. For years, the number of new infections related to injection drug use has been going down and staying down, and that's because of your work. So I ask you, why are lawmakers and even law enforcement so dumbfounded by this epidemic? Why they don't know what to do? Well, maybe they should just ask us. We're the experts. And that includes us at AIDS United, where we run the Syringe Access Fund. That fund over the last 10 years has given away $20 million to over 300 grantees, many of whom are in this room. Give it up for our syringe access grantees. And I'm proud to tell you that the Syringe Access Fund pays for 40% of all the needles exchanged in this country. 40%. And our partner for this plenary, the Harm Reduction Coalition, is a national expert on policy and advocacy and technical assistance for harm reduction. So we're going to have today a panel of experts to tell us about the impact of this epidemic on us, the HIV community, and especially communities of color. But before we do, we have another moment to remember. Dan Bigg. Dan was a lion in the harm reduction movement. Dan was a co-founder of the Chicago Recovery Alliance, one of the first to respond to that epidemic in Scott County. He was a leading voice for access to naloxone in this country, and he was a mentor and champion for our community. We lost Dan just 3 weeks ago, and he leaves a wife and 3 children. We remember Dan this morning, but we also remember the 72,000 Americans who died last year from drug overdose. 72,000. Many had HIV or viral hepatitis or both. Let's remember all of them and Dan now. Thank you. If anyone was at karaoke last night, you know that I love the performing arts. I love the visual arts as well. So I want to tell you that the photography you've seen this morning on this screen was taken by Robert Suez, who will be one of our panelists today. He's an expert, and his depiction of the epidemic is just beautiful. Give it up for Robert. And the music you've been hearing today is music by artists of color whose artistry and whose deaths were related to overdose. People like Billie Holiday and John Coltrane and Jimi Hendrix and Sylvester. We're still inspired by their artistry. All right, so let's get deeper into this subject. And to do that, we have an expert from the field. She's a senior research specialist at the Human Rights Watch. Please welcome Megan McLemore.
Hi, everyone, and welcome to my home state of Florida. So let's get local. Consider this. Every day, 20 Floridians are dying of drug overdose. More than 5,000 died in 2016, and there is no end in sight. In a state with some of the highest rates of HIV infection in the country, the third largest state in terms of population, and a vast geographical area, we have one syringe exchange. Why is this true? How can this be? It may be that it is counterintuitive to provide a needle to someone who is using drugs. I get that. But science tells us it's the right thing to do. Overwhelming science, decades-long science. It's a huge body of evidence showing that syringe exchanges reduce HIV and hepatitis C transmission. They bring people into health services, including drug treatment, and they don't increase drug use or community crime. They're also the most direct way to get naloxone, the overdose reversal medication, into the hands of those who need it the most. Our one syringe exchange program in Florida has reversed more than 700 overdoses in just a year and a half. In North Carolina, syringe exchanges have reversed 12,000 overdoses since 2013. It is also the most effective way to get PrEP into the hands of people who inject drugs, something we need to talk much more about. So what does this tell us? The United States is not experiencing an opioid crisis. The United States is experiencing a public health policy crisis. Why is there such resistance to science? The #1 barrier to implementing public health interventions for people who use drugs is the criminal law. Drug paraphernalia laws in many states, including Florida, are preventing expansion of syringe exchange. We went through an intense campaign here in Florida last year to pass a bill that would have permitted, not required, permitted counties to approve syringe exchanges if the county health department felt it was necessary to protect public health. This bill was opposed by the Sheriff's Association, and it failed. Apparently, as a society, we consider it more important to put people in jail than to save their lives. And as HIV advocates, we see this. We see this in HIV criminalization laws, which have been shown to reduce HIV testing, spread misinformation, and increase stigma and discrimination. We see this because the same populations that are at most risk of going to jail, men and women of color, trans women, LGBT youth, sex workers, people who use drugs, poor people, and immigrants, are the same people who are at the highest risk of HIV. And we know that the criminal justice system is bad for your health. We know that even a short jail stay can have a huge negative impact on individuals, on families, on communities. Going to jail impacts income, housing, employment, and it's a very violent place. All factors tied to increased HIV risk and poor health outcomes. But HIV policymakers don't talk very much about criminal justice reform. When they talk about jails and prisons, they talk about linking people to care when they get out. That's important, but we need to talk about keeping people out of jail in the first place. So during the push last year to pass the syringe access bill, we made this film to help educate people, from legislators to the community and law enforcement, on what is syringe exchange and what does it do. We're going to show you this film now, and we hope that you will join us and support this bill when it comes up again this year, because it's not just a matter of public health, it's a matter of human rights. Everyone has the right to health, including people who use drugs. Thank you.
Derek was 17 when he took his first pill, and he died just 2 weeks after his 18th birthday. Even after my child died, that certainly wasn't the end of it. Other people died. One of my son's best friends, when she was 20 years old, told me that she had already been to 11 funerals of friends that they all grew up with.
The United States is in the middle of an opioid crisis. Nearly 100 people a day are dying just from opioid overdose. One of the most effective responses to the opioid epidemic is through a frontline public health intervention known as syringe exchange. Syringe exchange programs not only give clean needles to people who are using drugs, they take dirty needles off the streets. They also reduce HIV and hepatitis C transmission and offer naloxone, the overdose reversal drug, to reduce overdose deaths. Right now there is only one syringe exchange in the state of Florida, and that's in Miami.
We're going to find needles here in this patch of grass. You used to be able to find a lot of needles under those trees. Don't find them there anymore. They know that for every needle they bring me, I'm going to give them a needle.
We have this wonderful program for people here in Miami, but I feel that until this is in the entire state, we cannot stop. Unfortunately, Florida's had the highest rate of new HIV infections in the country, and we had this huge opioid crisis. After the pill mills closed, there was lack of access to opioids. People were pushed towards using street drugs, and then they had no access to clean syringes.
If you got your drugs and you're an IV user and somebody else has a needle and you don't, you're not gonna not get your fix because their needle's dirty.
We've handed out about 90,000 needles. We've done hundreds of HIV and hepatitis C tests. We've been able to link people to care for HIV. And we've also been able to get people into substance use disorder treatment.
Originally, they were helping me to keep my habit, for me to do it as safely as possible. But when I found out about the treatment options, and I took advantage of that almost immediately, I was able to get clean, I was able to get my family back, I was able to get off the drugs.
Syringe exchange programs cost very little and save the public millions of dollars.
When I have a patient in the hospital who has endocarditis, which is an infection of the heart valves that comes from using dirty needles, just that person's hospitalization could pay for a needle exchange program to operate for an entire year. And that's one person.
We have one of the largest overdose rates in Palm Beach County in the state of Florida. I see this needle exchange program as absolutely something that we need to support and make happen.
So all we're doing is like, here's something that can help stop disease. Here's something we can do that costs a few cents. So why don't we just do that? And the only reason to not do that is if you don't think those people are worth helping or saving. So, I mean, that's where it becomes like a human rights issue for me. It's like, these lives are worth saving.
What kind of family does a drug user come from? Well, you can come from any family. These kids could not have been loved more. They couldn't have.
There is going to be a huge fight as we make a meaningful response to the opioid epidemic nationwide. And any response has to include needle exchange. If you're not including harm reduction, you're really not addressing the problem. If you're not looking at HIV prevention, if you're not looking at overdose prevention, the handing out of the naloxone, you're really just not doing anything for the opioid epidemic.
And now I'm honored to introduce another very important video from our colleagues at AMFAR. This video addresses the myth, and it is a myth, that the overdose epidemic only affects white people. So enjoy this next one. Thank you.
So now I want to talk a little bit about opioids and race. One thing that is really clear in the United States is that we're seeing a trend where there are fewer black injectors, new injectors in the U.S., and a trend to more injectors who are white in the U.S. So when you take a look at 2005, for instance, you see that among new injectors, it was fairly even for whites as compared to African Americans. But by 2015, we can see that in terms of new injectors in the United States, that whites dwarfed African Americans in terms of who was new to injecting in the U.S. And that trend, unfortunately, has been continuing for some time. And when you take a look at opioid-related mortality in the U.S., you see from 1999 all the way through 2016 that mortality has been greatest among whites in the U.S. Compared to blacks or to Latinos. So what we see in terms of the opioid epidemic is that it's not just new injectors, but we're seeing that opioid mortality is highest among whites as compared to African Americans in the U.S. So what many people have thought is that, well, perhaps maybe this is because blacks somehow are immune to opioids, that, there's a reason why we're less likely to use opioids. And, there's really one reason why African Americans overall are less likely to use opioids, and that reason is racism in the medical community. There have been several articles that have looked at opioid prescribing for African Americans. There was an article that was published in JAMA that looked at emergency room prescriptions for opioids of blacks compared to whites and found that blacks were less likely to be prescribed opioids. There was another one that was followed up in pediatrics several years ago that found exactly the same pattern for children, that physicians are less likely to prescribe opioids to minority children as compared to white children. So race and racism is a big issue of this, and part of the reason that African Americans are less likely to be prescribed is a belief among healthcare providers that African Americans are more likely to tolerate pain as compared to whites, and also more likely to abuse drugs if they had access to these types of drugs. So unfortunately, that has been part of the reason why we see prescription rates as well as overdose deaths among African Americans less compared to whites, is because of racist prescribing practices. And there are a lot of people who have called this out. There is a really nice piece in PBS NewsHour talking about no wave of compassion when addicts were hooked on crack. And many of us remembered what happened during the crack epidemic, where there was very little sympathies that were out there for people who were substance users then, as compared to a lot of the effort and sympathies that are out there now because of the opioid epidemic, because it's affecting a different demographic. And there's actually a Brooklyn State Senator, Martin Golden, earlier this year, who was pretty explicit in his racism and the differences between the crack epidemic as well as the opioid epidemic, where he said that opioids aren't a ghetto drug. And I think we all know what he meant by that, that, opioids is affecting, mom and pop American who look like him, and are not a ghetto drug that's associated with communities of color. And there should be a difference in the way that we treat these drugs. And, there have been many people who've talked about the deadliness of the opioid epidemic and how it has roots in America's failed response to crack. And I think that that's very clear, is that if we had dealt adequately with the crack epidemic and instead of using punitive policies to put black Americans in jail, actually did more to beef up treatment programs and having reliable treatment programs with the effective interventions that were well-resourced, that perhaps we would be in a better place to address the opioid epidemic in the United States. So a lot of this is our failure to deal with the crack epidemic adequately. One of the things that you see, too, is geographic differences in terms of opioid overdose rates across the country. Now, these aren't necessarily fatal overdoses. This is data that CDC released earlier this year, where you could see consistently in the third quarter of 2016 to the third quarter of 2017 that most of the opioid overdoses in the country were in the Northeast and the Midwest, and with a sharp increase in the Midwest. They also reported that there's a 30% increase in opioid overdoses in 45 states, with 70% increase in the Midwest and 54% increase in large cities in 16 states. So not really just a rural phenomenon, but something else that's taking place within cities in the U.S. Another thing that's clear as well is that opioid overdose deaths actually vary by race and ethnicity in the United States in terms of what's taking place. So we can see here among whites, most of the opioid deaths are taking place in Ohio, in Pennsylvania, in New York, in Florida, concentration in California as well as Texas. For African Americans, it's Illinois, it's New York, D.C., and other places. For Latinos, it's California, Texas, Florida, as well as New York. So we're seeing some variability in terms of opioid death rates by race in the United States and the geography of opioid death rates. And that shouldn't be surprising because we also see geographic differences in terms of HIV infection by race and ethnicity in the United States, where most of the infections, at least among African Americans, being concentrated in the southern U.S. There was a really nice graphic that was shown looking at fatal fentanyl deaths per 100,000 people between 2014 and 2016. And you could see really clearly a huge increase in fentanyl deaths in Baltimore, Maryland, in Ohio, in Philadelphia, Washington, D.C., Cook County, Miami-Dade County, as well as New York. Now, for most of you, if I would tell you if there is a defining characteristic, other than these being major urban areas, that would define many of these cities, I think many of you would agree with me in saying that these are cities that have extremely large African American populations or black populations. So I think that there's a bit of a myth when we talk about the opioid epidemic only or primarily affecting whites, when we're seeing in primarily black cities these huge increases in fatal fentanyl deaths over the last several years. And that really came into sharp relief for Cleveland, where Cleveland officials were talking about a sharp rise in opioid deaths among African Americans between 2014 and 2017, where they were just seeing a sharp year after year rise of deaths taking place among the black American community. Here in Washington, D.C., most of the deaths that are associated with opioids between 2014 and 2017 are among African Americans. And we actually see that opioid deaths have eclipsed homicides in D.C. between 2014 and 2017. So we're seeing that there are glimpses where African Americans are more likely to use opioids or more likely to die from opioids compared to whites, and we're seeing increases in subgroups where we thought perhaps we wouldn't see those increases taking place. And it's not just African Americans. We're seeing among Latinos as well, and this is data from Massachusetts, where Latinos are increasing in terms of opioid deaths. These are data from 2015 and 2016. Look at the jump in opioid deaths for Latinos between 2015 and 2016 in Massachusetts, from 19% all the way to 31%, which is a huge increase just in that 1 year alone. So just because these populations are not using meth or opioids to the same extent that whites are, it doesn't mean that at some point that's going to change. This chart alone, showing what's taking place in these primarily minority communities, minority cities, should give us a lot of us pause in terms of what might happen with opioid use over time within many of these places. And certainly meth is a nice indicator with the switch that we're seeing with many more black men who are reporting meth use, and with it reducing among white men, as something that we could possibly see overall with opioid use as well. I think the last thing that we need to say is that we just have to be very careful when we take a look at some of these demographic trends, because it's pretty clear that these trends are catching up with us. There's actually a study that was just released in the last few months that found that prescriptions for opioids for African Americans is on par with prescriptions for white Americans, which certainly should give us pause that what we might see coming in the future is going to be problematic, particularly for African American communities and the opioid epidemic. And it really begs the fact that we need to address a lot of these disparities, from HIV infection to hepatitis C to opioids to meth, as a syndemic, that we know that HIV is inextricably tied to other health problems, including psychological comorbidities, substance use, sexual victimization, stigmatization, and multiple forms of discrimination. And until we actually really start treating many of these problems as interrelated, we're going to continue to fall into these pratfalls where we see these disparities in marginalized groups and where we really don't make meaningful impact in any of these populations.
Please welcome Monique Tula, Harm Reduction Coalition.
Thank you. All right. Hey, what's up now? Good morning, everyone. Listen, I want to tell you that I'm standing up here angry. I'm grieving. I'm upset that this is the last plenary of the conference and we're just now talking about the opioid epidemic. You can't watch the news or scroll through your social media feeds without hearing about another overdose, another death to overdose. Last year, Prince died from an opioid overdose, likely because there was fentanyl in it. In fact, I think they found it in the autopsy. And fentanyl, if you don't know, is 50 to 100 times more deadly, stronger than heroin, than street heroin. Last summer, singer Demi Lovato overdosed, and she was fortunate, though. Somebody around her had naloxone to reverse that overdose, so she didn't die. But 2 days ago, rapper Mac Miller did die, right? We out here dying, y'all. Closer to home, my partner's colleague who works with him at the Harm Reduction Center in the Tenderloin died from an overdose, and that's not 3 weeks after the death of Dan Bigg that Jesse mentioned earlier. Dan was the architect of naloxone distribution, and naloxone is the antidote to opioid overdoses. I knew Dan very well, and his death cut me to the core, as it did the rest of the harm reduction community. It happened on August 27th, 4 days before International Overdose Awareness Day, which is a global event that's designed to raise awareness about overdoses and drug user stigma. Dozens of events took place this year. And notice I said dozens, I didn't say 100. I didn't say 1,000, but dozens. Dozens of events took place this year, many of which honored Dan, because what he taught us is that asking permission not asking permission is far more important than just doing it. Thanks to his example, people all around the world, lay people all around the world, have reversed tens of thousands of drug overdose. He didn't wait for policymakers to come around to the idea, he just did it because it was right. Dan was one of the founding members of the original Harm Reduction Working Group, and this year is that group's 25th anniversary. They came together fueled by the collision of the HIV/AIDS crisis and the war on drugs. This was a small group of visionary people that made the bold decision to care for and advocate alongside people who were using drugs who were dying from AIDS. And that decision gave rise to an entire community of harm reductionists who have this anarchistic vision to just keep ourselves alive while trying to dismantle the prevailing criminal justice system of the time. And quite frankly, it's still here. There's not much that's changed. So the founders of the harm reduction movement were predominantly people of color. They were people who used drugs. They were people who used to use drugs. They were queer activists. They were members, veterans of the ACT UP movement, and together they began to change the way we treated people who use drugs. But here we are, 25 years later, and we out here dying, y'all. People who use drugs are more vulnerable than ever. Despite what we know about HIV transmission, if you don't have access to a syringe service program in your location, you will use syringes. You will share syringes, right? We know that people who are living with HIV face a ton of challenges when trying to access healthcare, and it's doubly more difficult for people who use drugs who are living with HIV to get access to treatment and care. And these challenges stem from structural and social and cultural prejudice about drug use. There was a study in cities that had high levels of HIV, and in this study it found that about half of people who inject drugs reported being homeless, about 25% reported having a history of incarceration, and about 16% said that they didn't have health insurance in the last year and the previous year. People who inject drugs face stigma and discrimination because drug use is viewed as a criminal activity rather than a medical condition that requires counseling and rehabilitation. I'm angry because we're living in an era where increasingly people who have experienced intergenerational trauma and poverty and social isolation and homelessness and untreated mental health issues are turning to drugs to cope, and the drug supply is more dangerous than it's ever been. The average life expectancy for white American men without college educations is declining for the first time in decades. And what's killing the white working class is not heart disease and diabetes, it's alcohol-induced liver failure and opioid addiction. For white working class guys, things ain't looking so good. But let's not get it twisted. As we just saw, the opioid crisis is not just affecting white folks. So think about some of the most popular music that's out there. Anybody here listen to rap? Migos got that song Slippery, where Offset's talking about popping Percocet and drinking purple just to get warm, right? Or rapper Post Malone, who's talking about fucking hoes and popping pillies and feeling like a rock star. Okay? This is what our kids and our grandkids are listening to, and maybe it's what they're aspiring to. And my point is that we have a situation that rivals crack in the 80s and the 90s. Jesse mentioned 72,000 people. That's one person who's dying from a drug-related overdose every 7 minutes, y'all. Every 7 minutes. It's more people who died from HIV at the height of the epidemic. If there was ever a time for scaling up harm reduction strategies, it is now. It is time for a national harm reduction strategy. Just like we had a national HIV strategy, and for hepatitis C, we need one for harm reduction. Because next week, it might be your colleague, or your friend, or your brother, or your mother, or your child who ODs. Thank you.
Ladies and gentlemen, Robert Suarez, Vocal, New York. Ooh. Okay, he has...
Oh, good morning. Good morning. Can everyone hear me? Good morning. I say good morning. I say good morning because there's a lot of people who are not here this morning, right? Unfortunately, a lot of people are not with us. As you've heard from many of the statistics, in 2016, we lost 42,000 individuals to unnecessary overdose. That's 2016. In 2017, we lost more than 72,000. Wrap that, see if you can get your head wrapped around that. 72,000 people died in 2017 of an unnecessary overdose. That's more people than the Vietnam War. That's more people than World War II. We're losing. Let me be clear about a few things. When it comes to people who use drugs, when it comes to my community, yeah, I said it, we are amongst the most talented, gifted, and blessed individuals on the planet, and we can't afford to lose not one more. Not one more. A little quick history. My mother was an intravenous drug user. I lost my mother to the complications of AIDS in the year 2000. She died in my arms in Harlem Hospital. We did not have harm reduction during my mother's time. We have it now. And we are still fighting the longest running failed war in U.S. history. Once again, 7 presidents, more than 4 decades, more than $5 trillion spent on fighting the longest running failed war in U.S. history. This is nothing but a form of genocide that must end. Now, when it comes to my community, yeah, I said it again, because I want to be clear. When it comes to my community, you've heard me state it, and I'll continue to state it. We are amongst the most talented, gifted, and blessed individuals on the planet, and we can't afford to lose not one more. I would not be standing here today. I would not be standing here today if not for organizations like the Harm Reduction Coalition. I would not be standing here today if not for individuals who stood beside me, who flanked me on either end and held me up, who said, we won't let you go. And that's being done all across this country. It's not being done enough. We need to make sure we continue to do more of it. I like to talk about people who use drugs as those who are the haves and those who are the have-nots. The haves are the individuals that are in their condos, right? In their big homes that we never ever see. The have-nots are the individuals who are homeless, the individuals who are unclean, who are dirty, if you, for lack of a better word, right? The individuals who are nodding out on those trains, those buses, in those parks. The individuals that most people don't want to even be around. These are the individuals that we're fighting for. These are lives that are getting lost. These are the people who are the gifted, the blessed, These are the people who deserve to live. These are human beings, my friend. The next time you see an individual nodding out, don't shake your head no. Don't do it. Step up. Be a human being. Find out if that individual is all right. I'm not saying give them no money. Find out, are you okay? Are you breathing? Are you breathing? Because if you're not, we're going to make sure we get you some help. These are human beings, my friends. Now, they say I'm some kind of an expert. I don't know. The experts helped get me to where I'm at. The experts helped educate me about harm reduction and the principles of harm reduction. First, doing no harm to myself, right? And then helping me understand that if you're going to use, try and find some kind of a happy medium with using, you know? Like, Robert, you're going to be speaking today before a crowd of a couple of hundred people in Orlando. May not be a good time to use. Okay, cool, cool. Another principle of harm reduction is after doing no harm to oneself, after finding that possible happy medium or means of using with a balance, hopefully, in some way, if an individual chooses, finding that road to abstinence. Something that we all aspire to. We don't always do it. But the one thing that we do in harm reduction is we make sure that when it comes to self and other individuals, we take care of ourselves. We take care of ourselves. And you know, in one way that we take care of ourselves is making sure that we have other individuals around us who care about us, right? Each one teach one. Each one takes care of each one. We are all human beings. And when it comes to our government, right, so it's a form of genocide, my friends. 72,000. It's time for us all to stand up in one voice and say, no longer. No longer. No longer will we allow this genocide to continue. No longer will I lose a sister. No longer will I lose a brother. No longer will I use a mother, a father, a friend, a neighbor. No longer. No longer. No longer. No longer. No longer. My name is Robert Suarez, and I am a leader with an organization called Vocal New York that builds power in low-income communities. I am a member of the Peer Network of New York, another organization in New York City that builds power with peers in New York City. Let's be clear. I also sat at one time on the board of directors for a UK international advocacy company called Input, which stands for the International Network of People Who Use Drugs. This is not just local, statewide. This is not just a US thing. This is a national movement that we all need to be a part of, because those numbers are just reflected in the United States. There's a global genocide going on when it comes to people who use drugs. My name is Robert. Thank you.
Dion Haywood, Women with a Vision.
Hello. Hello. You better clap because I have my Nikes on. I don't know about y'all, but Robert just got me. And Robert made me almost flip what I thought I was gonna say. And so I want to talk to y'all for a few minutes about the possibilities. Y'all with me? I know it's lunch, I know some of y'all gotta go, but I want you to just work with me to dream about the possibilities. So my name is Dionne Haywood. I'm the executive director of an organization called Women with a Vision in New Orleans, Louisiana. And Women with a Vision was started in the late 80s by 8 black women who just decided they were tired of black people being left out of what was being done for people with HIV. They ain't had no money. We still don't have a lot of money. But next year we'll be 30 years old, and that is the possibilities. One of the main leaders in Women with a Vision at the time, her name was Danita Muse. And Danita just retired at age 60 as a substance abuse counselor. And she knew that something out there had to be different than 12-step, right? There gotta be something else than 12-step. There gotta be something that gets people through that's not asking to do something that they cannot do, physically unable to do. And so that was harm reduction. And I want y'all to remember what I just said. Women with a Vision will be 30 years old next year. And so she met people like Dan and Imani Woods and Dave Purchase, who all visited us in the South, in New Orleans, and they taught us what we needed to do. And we are, till this day, are still running an underground, illegal syringe access program. So when I talk about possibilities, some people would describe Women with a Vision, oh man, they're a radical black feminist organization in the South. Oh man, they are a reproductive justice organization in the South. And I always come back to, we are a harm reduction, radical feminist, black feminist, reproductive justice organization that focuses on HIV and women's health and works with drug users and stands with trans women and stands with queer people. That is who we are. So I had a question, because I have actually not attended this conference in a couple of years because I was a little disillusioned. And for those of you who know me personally, I don't like being disillusioned by anything. I live in truth, reality, the here and now, and how much we're gonna get done together. It is also my belief that if you do this work, if you have not been trained in organizing 101, you need to ask your organization to find a training, or you find it and give it to them, because you need to know what it means to go out and talk to people. Now you would say, well, yeah, we do outreach. And yeah, we talk to people. But if you're not talking to the people that Robert just mentioned, you ain't doing nothing. And I'm not saying you're not working. I'm not saying you're not working. But the HIV movement, y'all, we've become real safe. Y'all heard me? We're safe. Well, I don't want to ruffle no feathers. We get our little money and we right here. So I'm telling you about the possibilities of an organization in one of the most racist states in this country who said, well, we're just gonna do it. We're gonna do it, and have been doing it, and continues to do it. And organizing, or should I say policy without organizing is death. Did you hear me? If you're sitting in your office and you're meeting with officials and y'all are the only one talking about the policy you say you're working on for the people, you're causing death to your people. Because I promise you, if the people are not at the table and the people can't hear you and the people are not involved, you ain't got shit. How many of you have seen policies being changed in your state, in your city, nationally, and everybody was like, we gotta win. Yes, Ooh, we won, we passed the law. Same shit still happening. Probably because you didn't go out and organize with the people, and you didn't go talk to the people, and didn't ask them how it was going to be implemented. So all of these three major things that I see people talk about. Oh, policy, policy, policy. Yeah, policy. We do policy at Women with a Vision, and even as ED, I still feel like sometimes it's because it's a part of it. It's not the whole strategy, it's just part of it. And then there's the outreach piece. And then there's no peace. Y'all know what I mean by that, no peace? Again, if the people most affected are not walking into your office and you ain't go get them, reevaluate that. If you work for an AIDS service organization or whatever organization you may work for, and y'all don't have a harm reduction program, you're missing out on the possibilities. Because I'm going to tell you the beauty of being a Black feminist organization, the beauty of being a reproductive justice organization, and understanding the history and the beauty and the strength of harm reduction is that we use it in everything we do. Our gender violence programs, harm reduction. Oh wow, sex workers, harm reduction. Not just about their drug use either. But it's like Robert said, like, now, how you gonna get through today? How we gonna avoid the police? How you gonna keep your kids? How are you gonna live? Harm reduction is so beautifully powerful that some of us do it every day and don't even realize we're using it. If you got up this morning, or for some of us on medication, and you say, nah, I'm gonna go ahead and drink these drinks. I ain't gonna take that medication today. I'm gonna wait till in the morning and take my medicine. Harm reduction. You hear me? You're practicing something so natural that you don't even know it sometimes. What keeps us from owning harm reduction is the idea we have to please people. Come with me. The idea that morally, drug use is so wrong. And morally, those people are over there. And I'm just trying to jump over here. And I'm better than is what keeps a lot of people from recognizing the beauty and the strength of harm reduction. So my challenge, and I did say challenge to you, is if you don't know what harm reduction is, get on that Harm Reduction Coalition website. Ask somebody who knows. Find out who's practicing harm reduction in my city. Is there anybody practicing harm reduction? Can somebody come talk to us about it? Do your homework. And the last thing I'm going to say is, we say, oh, intersectionality. How many of you know who coined the phrase, who came up with the term and its definition? Hands? Oh, Dr. Kimberly Crenshaw, Black woman, Columbia University, law professor. She was Black. She coined intersectionality to say, we are not one issue people. Black women, queer women, trans women, none of us are one issue people. So one method is not going to be the answer for everybody. If you say you are who you say you are, if you say you are what you've been walking around this conference this week doing, hey, I work for so-and-so, I do this, do it. I challenge you to do it. I challenge you to be intersectional. And if you say, I want to end stigma, but you got an issue with trans women, sit with yourself. If you say, I want to end stigma, and you got a problem with people who use drugs, sit with yourself. And the last thing I will say, this is not a plug for Monique or the Harm Reduction Coalition. This is a plug for me, a black feminist, an activist, a mother, a grandmother, a lesbian married to a fine-ass woman, that you join us in New Orleans in October for the Harm Reduction Conference. Get your people to send you to the Harm Reduction Conference. Thank you.
Well, we are fired up. We're fired up by the inspiration and the challenge that we've heard, the challenge from Robert that we be human, the challenge we just heard from Dion about the HIV community and our commitment to harm reduction, and the challenge that we heard from Monique about policy and activism. Let's take it right there. Let's take it right there. But none of you talked about mass incarceration as it relates to people of color and the opioid epidemic. I'm going to take you there.
Okay.
What is this?
Let's go.
What is this about the, what is this about the racialization of drug policy as it relates to mass incarceration of our people? Who's going to go first? Monique, you
May
start.
I?
Yes.
Monique, you start. You're the
My
ED.
sister.
All right, Dion, you go.
My sister, I love you, sister.
I love you too.
The war on drugs, that term, that was a term coined by Nixon in 1971.
Yes.
All right? He said that, he ordered that law enforcement focus their attention on consumers of drugs, okay? But that wasn't the first time law enforcement or drug policies was turned on consumers. More importantly, drug policy in the US is grounded on this concept of zero tolerance, okay? It's a principle that dictates that strict enforcement and punishment, right, reduces personal drug use. So in other words, if demand for drugs decreases by locking everybody who uses up, then sellers ain't gonna have nobody to sell to. How successful has that been?
Right, yeah.
Right. Okay. The first anti-opium laws in this country in the 1870s were directed at Chinese immigrants. All right? The first anti-marijuana laws in this country were directed at Mexican immigrants and Mexican Americans. And the first anti-cocaine laws in this country were directed at black men in the early 1900s in the South who allegedly were raping respectable white ladies while they were all hopped up on cocaine, all right? And then a century later, the political hysteria that surrounded crack, okay, led to the passage of even more draconian policies and Just Say No, right? Bill Clinton, during his presidential campaign, advocated for treatment over incarceration. What's the first thing he'd do once he got elected? All right, despite what the US Sentencing Commission said that you need to reverse or eliminate the disparity between crack cocaine and powder cocaine, that he did the exact opposite. So when our communities, and I come from LA, and my father lived on Skid Row for a good portion of his life, and during the 80s, when our communities, when my community, when Dion's community, when Robert's community was flooded with crack by the CIA, challenge me on that one.
Come on, Monique.
Dion.
So whenever I'm asked this question, I feel like I can go into all the racial and the racism stuff that we know historically has happened in this country, but I really want to tap into who's policed. Who's policed? See, Robert told y'all about like the people who are in the condo. So I live in New Orleans, and there's a very fine neighborhood called Lakeview. And I actually saw it myself, some documentation that said they had more heroin users, opioid users in Lakeview than they did in some of the projects in some of the poorer areas.
Mm-hmm.
But you're not gonna get them because they rode in their Range Rover to their house. They probably got off from work, functioning, because drug users do function, by the way, functioning drug use, and went in their house and used, or never came out their house and just had it delivered to them. Either way, we have to think about who's policed. African-American neighborhoods, brown neighborhoods, people of color, our communities are under surveillance, y'all. It's why we are arrested more, and it also fuels the stigma and the internalized racism that we believe about each other, right? It's easy to think, well, you know, black people do this, if you don't understand how black people are policed. See, those of us who know the squad car, the same police in the same neighborhoods every day that drive by every 15 minutes looking at the same people, and we wonder why that person has been arrested 6 times. So it really is about how people are policed. Who is police? It's how we also need to connect to criminalization.
That's right.
Right. Let's be clear. The United States is 5% of the world's population. Yet, we are 25% of the world's jails.
Yeah.
25%. And that 25% is made up of black and Latino.
Yeah.
All right, let's just put that shit right out there. I'm sorry, I said it.
I said it too.
Yeah, I said it. Put it out there. Where our communities, black and Latinos, are not just policed or watched. We're attacked.
Yeah.
We're attacked. It's a straight up war. And I used the term earlier, failed war. Let me be clear about that. This is not a failed war. This shit's going exactly the way they want it to. All right? It's a well-oiled machine designed to keep us incarcerated, to kill us, designed to perpetuate a form of, I was going to say the F word, but genocide. Okay. Yeah.
We've replaced plantations with prisons and nooses with police bullets.
So earlier, Robert told us about a principle of harm reduction, doing no harm to yourself. But we have a principle in our community called meaningful engagement of people with HIV and AIDS. Is there meaningful engagement of people who inject drugs or who use drugs in drug policy and services in this country? If not, why not? What should we do?
Go ahead, Robert.
Wow, go ahead, Robert. You know what, so yes, there is meaningful engagement to a degree, right? When it comes to meaningful engagement with people who use drugs, whether that's heroin, crack, cocaine, or even marijuana for that matter, when it comes to meaningful engagement, it's important that we understand that individuals who are our researchers, our policy experts, cannot necessarily engage with individuals who are on the ground, who are impacted by these issues. That meaningful engagement has to come from, for lack of a better word, matter of fact, I'm not even going to use the word peer, from people who are past and current drug users.
Yeah.
Unless that meaningful engagement comes from those individuals, right, we will continue to be where we are, right? It's about the continued support of the Harm Reduction Coalition, the continued support of organizations like the Drug Policy Alliance, the continued support of all these organizations that support people on the ground, right, who are impacted, right, who go out into those communities, who say, you know what, you no longer have to be here. You don't have to die.
Yeah.
There are people who care about you. Not just me, but many others, thousands of others. That's the engagement that we must work towards continuing.
Dion.
So I'm going to speak from a Southerner perspective. Whenever we throw in the idea of morality and people who we think are doing something that we feel is not right, we end up feeling like we have to talk for them. They can't possibly speak for themselves, and not thinking about the whys people use drugs. Nobody's thinking about how you got there. And I'm not saying, when I say nobody, I'm talking about the thems. They're not thinking about how people got there or what drugs give them at the time when they're using. We're not always thinking about that because we always, if you see my pen, save us from saviors. Everybody want to save somebody but don't want to talk about how they got to where they are. Or if they want to leave, especially if you don't have something else for them. I love it when people say, oh, you should encourage women to come up off the street. You have a house for them? Especially, and I want to connect some things with people because I really want y'all to hear us. See, we tell women and tell individuals don't be involved with sex work, but we live in a country that in most cities don't even want to pay people above minimum wage. We don't want to talk about for women, we can't even get equal pay. So you can't remove something from someone, whether it be the coping mechanism or the survival strategy, or maybe it's just what they like to do to make money because it's better than maybe McDonald's, without replacing it for something. And that's what I mean when I talk about intersectionality. You can't be fighting for one thing because you believe this over here. You have to fight for all of it. All of it goes together. If you really want to change people's lives, you have to fight for all of it. You can't just, I don't know, that's part-time activism to me. That you're going to pick, I'm going to support this, but I don't believe in this. Don't go together, y'all.
Well, talking about fighting for all of it, we keep hearing in the news that there are going to be all these billions of dollars to address the opioid epidemic in this country. Billions of dollars. I can't even keep track of what the number is. How are we going to get it to make sure that it goes to our people and our needs and not to law enforcement to lock us up? Monique.
Well, that's a great question. I got to say, real talk, the irony is not lost on me in terms of why we're talking about that at USCA during the first plenary that I know of that's ever been focused on drug use in the conference's history. Harm reductionists have been fighting alongside the HIV community for 30 years, demanding, support for evidence-based practices like syringe service programs, but we were hogtied in the early days and continue to be because of the federal ban on funding for syringe service programs. So if we wanted federal funding, right, we had to implement those goddamn EBIs that were not effective, okay?
Yes.
And then in the 2000s, when I was working at a needle exchange in Cambridge, Massachusetts, during that first wave of opioid-related overdoses, we were sounding the alarm to the HIV community, begging for help to pay for naloxone, but the health departments that paid our bills, right, said, no, you can't use that money for that. All right, so because we're scrappy, we got creative, thanks once again to Dan Big. But this time around, the feds are throwing billions of dollars out into the community, going to substance use disorder treatment programs, and they frankly are scrambling to figure out how to use them, right? And the HIV community is taking notice, as it should. But my question is, if your organization is savvy enough to attract those opioid dollars, what will you do with them? Will you invest them in underground harm reduction program? Dionne just talking about an illegal needle exchange program that she's been running for years, right? Programs that have been out here unsupported, trying to prevent more drug overdoses, while AIDS service organization CEOs are making $300,000 a year with summer homes and pied-à-terres in the city. There's a disconnect here. There's a disconnect here.
Dionne, what are we going to do with those dollars? How are we going to make sure we get those billions to help us?
Before I say what we're going to do, I want to give y'all an example. So my staff, our harm reduction staff at Women with a Vision, I walked in the office one day and they were fired up. They kind of like me. They were fired up and they were like, we went to this meeting that a quote-unquote substance abuse clinic place, whatever, And they called us and said they want to meet to talk about these new strategies that they came up with. And they were like, okay, and they was like, it's a thing called harm reduction. And they said they almost fell out their chair because there was like a new thing, and then they didn't even explain it right.
Brand new, brand new.
So to answer your question is, if you're a large organization that already have like what I consider to be $5 million and up, or a $40 million budget, and you never ever thought about harm reduction before, and you never thought about people dying of overdose, and you never really thought about drug users other than a way to pull them in and put them out. I know y'all want your job, but I would challenge that. Because that's the other issue, is that we're not challenging the people who chase the money, and a call out to funders and organizations where this money may be passing through.
Right.
Y'all know these people don't have a history working with people. Y'all know they don't have a history on the ground. But what you like and what's comfortable for you is, oh, they've been in business, they could do it. Don't fall for that. Don't fall for that. Support the people who's doing the work, and I really believe it's gonna come down to really challenging when this money comes out.
Right.
And letting people know that you don't get to just, we've seen it in HIV for all of its history. The larger organizations get all the money, their services didn't get any better, right. And people still in the same position. The people working for you still ain't making no money.
All right. All right, so we're talking about the money. We're gonna close this out. Panelists, close your eyes. Close your eyes.
I'll close my eyes.
You are on an elevator, and the governor, the mayor, or a senator just walked on with you. You have 1 minute to tell them what you want them to do for harm reduction. 1 minute. Go, Dion.
Damn. Wow. A minute. I want you to decrim drug use. Mm-hmm. I also want you to let all the people that are incarcerated right now for marijuana out because white people are getting rich. Decrim.
Decrim. Robert.
Decriminalize, 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 decriminalize. And if you don't decriminalize, that little twinkle you see in the corner of your eye is your political dissipation light shifting into overdrive. There are more people behind me, standing with me, who are ready to come up here to either Albany or Washington, D.C., who will make you understand. And if you don't understand, yes, seal.
Robert. Monique.
If you're not demanding unfettered access to buprenorphine or methadone, then you're not doing enough. If you're not demanding funding for harm reduction policies and syringe service programs in states, you're not doing enough. If you're advocating for safe injection facilities but not considering people who don't use needles, then you're not doing enough. All right? Yeah. And for our organizations, for our institutions, if you're not fighting to dismantle institutional racism in your own organization and the broader HIV community, you ain't doing enough. And then lastly, I don't know how much time I'm gonna have left, if you are advocating to bring the largest international AIDS conference to the United States that bans people who use drugs and sex workers from entering this country, then you for damn sure ain't doing enough.
Well, you heard it. You heard it. You heard it. Let's thank these experts. Monique Tula, Robert Serez, Dion Haywood. Thank you.
Hello, everybody. My name is Savannah Wanzer, and I'm one of the representatives of the transgender community. First of all, I would like to invite all of my trans brothers and sisters to come And we wanted to say a special thank you to Paul. If they haven't gone back home yet, we would like this moment for people to come on up that representing the transgender community. And also, we would like the first 2 NMAC transgender employees, Marissa Miller and Araya Lester, to come on upstairs and join us. Come on up. I would like to now introduce Ruby Corrado, who is the Executive Director of Costa Ruby in Washington, D.C.
Hello, everyone. I know many of you want to go home, but yeah, once again, we're in your face. I didn't mean that. Well, today, with an incredible team of powerful, let me repeat that, powerful trans women and trans men, we come to USCA once again, no longer just to make a statement. We are here to claim what has been denied to us since the beginning of the epidemic. We are claiming the opportunity to fight and to serve our own community with resources that have not been placed in leadership led by Black and brown transgender communities. If you read the reports that say that trans people are just an unknown population, here we are. This is a small sample of what we look like. As the leader of the largest transgender organization led by Black and brown trans people in the nation's capital, we've been doing the work for a very long time. And we finally make it to the stage. But I will tell you, make no mistake, we've been very busy. We have been very busy. We now have the largest shelter and housing program for trans people in the United States with over 100 beds. We now have the largest HIV prevention initiative for trans women of color and trans men that we will continue to empower. We now have the resources that we have fundraised. I'm going to tell you, it wasn't given. Most of it came from fundraising. And we are at the front line of the epidemic. So I want to remind everyone that we have built memories. These are some of the people that were at USCA, and many of us live with many memories of sharing the pain that is still happening in our communities. We are living with memories of those that are no longer here. We are living with the memories of the reminder of what is still happening to us across this country. But I also know we're leaving energized. We are leaving more empowered than ever. Now, we got a few promises. We'll see if they deliver. You know, some people made a few promises. They made a few commitments, so I'm looking forward holding them accountable. All of these people and the ones that left, we're really watching you. I am also leaving hopeful that for the first time, I saw more people attending the transgender-led workshops. Really? I've been in this conference before, and the rooms were empty before. So right now, I'm leaving hopeful that together we'll continue to do this work in our communities, and next year, and for the next 3 years, if I understand, you will see our beautiful faces and those that will join us in Washington, D.C., leading the work.
Now,
I want to say thank you.
Now, I would like to introduce my mentor and the executive director of NMAC, Mr. Paul Kawate.
Thank you for the love, baby. Yes, yes.
Thank you. No, I have a mic on. So let me say something. This is living proof that you can fuck up 1 year and still come back. I mean, it really, we fucked up last year, folks. We really did. And to have all of you here means the world to me. I want you to know that. This is the world I want to live in. This is the world I want to be a part of. This is the world that I believe in. And I know we fucked up, and so thank you. Thank you for giving us a second chance.
Fuck up, no.
I know. Thank you.
Thank you.
And let me say something to all of you, because this is the important thing. NMAC was always pro-trans. We were always supportive. That's not the issue. The issue is this. We hired trans staff. When we hired trans staff, it completely changed the nature of our organization. And so this is the challenge that I make to every single AIDS service organizations in the room. Hire trans staff. It will first of all, it will absolutely change the nature of your organization, but more importantly, it will give professional jobs to people who deserve to have professional jobs. So that next year when we come back, I'm a little afraid we're not going to be able to top this year, but next year when we come back, I want you to bring your trans staff to USCA. I want you to bring the celebration of the diversity of who we are, because this is just 1 year. Honey, we still got a lot to go, and there's still a lot of room. And let me also say this, we're probably going to fuck up again. And we're probably going to fuck up with another community. And what I want you to know is that it's not about making the mistake, it's about how you clean it up. And thank you. You as much as I want you to know that you believed in us, I hope you know how much we believe in you. And how much I just think your bravery and your courage to be who you are is an inspiration to all of us. And the reason that I love our staff is that all of a sudden, we've become a fun organization. We were not a fun organization before, and they have brought fun, they have brought laughter, they have brought joy, and thank you. Okay, sit down. So I have a series of announcements, and then I want to talk about something. The first thing that I want to say to everybody, and I'm sure I'm going to say this wrong, and so please, please, please forgive me, is I want to say Lashana Tova, which Lashana Tova means Happy New Year. And this evening is the start of the Jewish New Year. And to all of our Jewish colleagues who are here, we want to wish you a Happy New Year. One of the things that's really important You know, we are a culture of many, many, many communities. And I don't get to be here without also saying thank you to the host committee. So let me be really honest. We've had some crap host committees in my life. What city shall I say? No, never mind. And this committee went so beyond and did so many things. And I hope you know, I mean, that Saturday, the opening reception was all them. It was extraordinary. It was the first time we'd ever done something like that. And so thank you all so, so much. I also want to take a moment. Will NMAC staff please stand up who are here still? NMAC staff, you know, one of the things that happens, I guess there are no more NMAC staff here. One of the things that happens is, I think when you have an executive director like me, I tend to suck all the oxygen out of the room. And I know that. And so sometimes people think that this agency is just all about Paul Kawada. And it is so not true. The majority of our staff are women. The majority of our managers are women. Half of our directors are women. And let me be very candid with you. I am very clear about who I report to. And it's not my board, it's the women on my staff. They make NMAC what it is, and I want to thank them, because having a crazy Asian queen as your boss, I'm sure, is not an easy thing to do. I also want to thank, we started last year this thing, it's called a CAP, which is a constituent advisory panel, brand new for us. And like all of these things, you have no clue if it's going to work, if it's not going to work, and we still don't know if it's going to work or if it's not going to work. But there were a whole bunch of people who just said, we'll try it with you, and we'll stand up with you, and we'll learn with you. And once again, that was about fucking up last year. So will my caps stand up who's left here? Are any of my caps left here? Come on, thank you. And finally, I want to thank my board. As you can imagine, I'm probably not the easiest person to supervise. I've been here a really long time. This is the start of my 30th year as the ED of NMAC. And it has been an extraordinary privilege to be here as the executive director. And it has been an extraordinary privilege to meet and work with all of you. I hope you know that you are my heroes. I hope you know that you are the reason that I do this work. You are the reason, you know, I was a kid when the epidemic started. And I read these words from this man that I had no idea who he was. But it talked about the fact that if you're not mad as hell right now, then we're in trouble. Larry Kramer changed my life. Larry Kramer was, yeah. Larry Kramer was able to put in writing what I needed to hear so that I could understand that it was okay for me to stand up and be out about who I was. It was okay for me to stand up and fight. It was okay for me to be a part of something that was so much bigger than I was. You know, I'm sure most of us, none of us thought, oh, I'm going to be an AIDS activist when I grow up. You know, that wasn't even a thing. The only thing that we knew was that people that we loved were getting sick. The only thing that we knew was that people that we loved were dying, and we had to do something. we have this amazing group of people over 50 living with HIV as part of NMAC. And I always tell them they are the heart and soul of USCA. They're the heart and soul because they are the survivors. They are the survivors who got through the ugly, awful, almost unexplainable early days of the epidemic. I am one of the founders of the National Association of People with AIDS. There were 33 of us who came together to build that extraordinary organization. And I'm the last one alive. And it's hard to be the last one alive because you feel the responsibility and the memory of all of those amazing human beings. The people who taught you and brought you to where you are. And one of the things that I've learned about leadership is that it's not about being right. It's about how can we work together as a community. It's about how do we include the diversity of opinions and people. It's about how to have the most fabulous dinner party in the world and include everybody that may not be like you, but is committed to fighting and making a difference in this world. And you are my fabulous dinner party, and so I thank all of you for being here. So this is between us. We have a closed room. I'm sure no one's recording this. I need to ask you a question. So someone just talked about 2020, the AIDS conference. And so NMAC has been trying to figure out, so what do we do that year? What would make a difference that year particularly, and how do we want to position USCA? So one of the things that we're thinking, and I would really like to hear by clapping, and we'll talk about this, what you think. We are overwhelmingly sad about what's happening in Puerto Rico. We believe that Puerto Rico is a national disaster that needs attention called to it. We believe that Puerto Rico is a place.
Silence for them.
We're about to do that, honey.
Okay. You know me, I speak up.
No, that's exact. And so I want to know, if I bring USCA to San Juan, will you? It will probably be a much smaller meeting, but that's not the size is not always the most important thing. Well, and but I think that we as a community have a responsibility to stand up and say what is happening in Puerto Rico is wrong, and that they need our tourism dollars, and that they need us to come back and stand with them. And so, if you all don't mind, will you please stand so that we could have a moment of silence for the 4,000 people who died during the hurricanes. Thank you. My message to the people from the island is, we will not forget you. My message to the people from the island is that we will stand with you and we will fight. But let me also say one other thing. The island has to sign off on this. You know, they already have how much work that they have to do. And USCA is, as you probably know now, not an easy thing to do. But I think that it makes a really important statement at a really important time. And so I will be actually putting out a poll and be talking to folks, and if this is something that you're willing to stand with us, we sure would appreciate it, because we believe in Puerto Rico. We love my Puerto Rican delegation. I love you guys. Oh my God. I just love you so much. I hope you know that. I hope you know how much you love me.
We will do it.
Honey, I just love you all.
We will do it. We will do it.
I love you so much.
We will do it.
So this is a surprise to them. They did not know I was going to make this announcement. So thank you guys so much. You know, one of the when you come to these meetings and you get to watch, there was a huge Puerto Rican delegation this year, and I was so overwhelmed by the fact that they were able to come, and I wanted them to know that we stand with them. So now, let me get back to my video introduction. So I'm about to share with you a video from my hero. I'm about to share with you a video from one of those people that changed the course of my life. And what I want you to know about it is this. First, it's a little long. And so one of the challenges we had at the opening was that in order to get all of those beautiful and wonderful people up on stage, we could only do it so long. At the closing, we have a little bit more time. And so we'll play the entire thing unedited. I want to say a couple things about this. Getting this video for me has been the privilege of my life. You know, have you ever had an opportunity to email and talk with one of your heroes? For me, it made my mind explode because I had never, you know, I'd only read, well, actually, no, this isn't true. Larry and I got an award back in the 90s together on some stage. And Larry walked up and said, "We're all going to die, let's go home now." And then they said, "And here's Paul Kawada." And so Larry has always been a hero of mine. He is someone who gave me permission to fight. He is someone who stood up when nobody else stood up and said no. So we've been having this email relationship, and I've been able to tell him all the things that he did for me. And so I wanted to do it here right now. But I also wanted to say one other thing. So Larry's a little mad at me because we cut the video. He's a little mad at me, and I completely understand, and he's right. But how cool is it that Larry Kramer is mad at me? I mean, it's kind of like an activist wet dream. You know, it truly is. It is one of those moments that you think, he even knows who the fuck I am. I mean, you know, it's, and so what I want you to know is that Larry can be as mad as he wants. I find that thrilling. I will always love him. He changed the course not just of my life, but of this movement. His words inspired and challenged and moved so many of us, both to call to war and to fight back. And that's what I want all of us to remember, that this is still a war, that this is still a battle, that we still have to fight, that it is not over until we find a cure. And it's really important that we remember that, because there are over 1 million people living with HIV. So even when we end the epidemic component of this, we still have a huge responsibility to people living with HIV. And so please, enjoy Larry as only I could enjoy Larry. Thank you.
I apologize for not being with you. I had hoped to come. I had looked forward to meeting and talking to other long-term survivors. But my 83 years of living is currently exercising a no-travel request. Please forgive me. There are a lot of things I could talk about. I've rarely been at a loss for words. But what I'd like to talk to you about today is a few things I've learned since I came out in 1950-something. The most important thing I've learned is how much I love being gay. I love gay people. I think in many ways we're better than straight people. We're more loving. We're better friends and at friendship. We're kinder to each other. I think person for person, we're more talented and creative and imaginative. I feel proud and grateful that I'm gay. I look upon it as a great gift. I identify myself first and foremost as a gay man. I've learned that the most important skill I've acquired is how to become a writer. I love being a writer. If I couldn't write, I'd just as soon not be here. Learning to be a writer, like learning to love being gay, has taken a while. You have to stick with it and be patient as you learn from them. I've learned that becoming a writer has given me the greatest tool to fight back with, because the hardest thing I've had to learn is how ineffably sad life is. This has been a toughie and continues to be so. Everyone here I know has experienced this. There's not much that can be done to really alleviate sadness. It's here to stay, and we should learn as much as possible to not deny it. It helps a lot to do the kind of work we're all doing. Fighting back is one of the greatest gifts life can give to us, to live with sadness, although it doesn't come with fewer tears. I spend a lot of my time thinking of the sadness of our lives. I've written about this AIDS plague since its beginning. There's not a day that goes by without my learning about it, where it came from, precisely who our murderers have been and continue to be. I add or revise this history every day. My history of homosexuality, which I call The American People, well, I'm still refining Volume 2. It'll be out by Christmas 2019, and then you'll have over 1,000 pages of what I think we've been through. I do think we have been murdered. In fact, I have no doubt about it. AIDS was allowed to happen, and in many ways it still is. As the late, great Dr. Mathilde Krim always maintained, AIDS has been allowed to happen. Learning this has, of course, contributed mightily to my sadness. It's also made me very angry. I've learned that anger is one of the great gifts and finest tools anyone can have in any arsenal of life. Anger is not only healthy, it's essential to living through sadness like we've been going through. Without anger, there's no effective way of fighting back. Fighting back has become the backbone of my existence, the reason for my living. If we don't fight back, our opponents and enemies won't pay attention to us. We become invisible, non-entities, disposable. We get nothing when and if we don't fight back. As a people, this is a lesson for our survival we've not mastered sufficiently. I know everyone here thinks she or he is fighting back. I believe your motivation is founded on love and fairness and decency. You believe there are good people in this world supporting your efforts, and like good neighbors, doing unto others is what you do. I fear that you don't believe in this efficacy of anger, its necessity. You prefer to believe in the power of love. But the powers that be, who have ignored us in AIDS, are not motivated by love, at least not the kind of love we have for each other and want so much from the world. But their love and our love are not the same, and probably never will be. This is also life's great sadness. It will never be conquered by love. The most awful lesson I've had to learn is recognizing hate. We who are gay and or with AIDS refuse to face up to this fact. We are hated. I am frequently criticized for saying this so bluntly, that we are hated. I do not mean dishonored, ignored, ridiculed. I mean hated. And this hate increases with every administration, with each passing day. People of color, of course, have witnessed and lived with this much longer than I have. But gays and people of color have been hated since the very beginning of America. What does one do with this hate? Just to call it a great sadness is a waste of time. As I said over and over through the years, we will always have enemies. Our enemies are not going away. Fighting back effectively requires facing up to and against hate. I also learned over the years of this plague that anger has brought us more tangible results than being loved and good little boys and girls. Every AIDS med out there we got because of our anger. But it took us too long to get angry enough to fight back for these drugs. With such success, why did we stop being angry? Why did we stop fighting back? Many of you think that we did and do fight back. Just staying alive was indeed fighting back. But we got the antivirals and we stopped fighting back and turned our energy, as you have, into helping each other with love. So I think the greatest lesson I finally managed to learn is that we are hated by many, and that we have always been hated by many since the beginning of time. And the best way of dealing with this is not by loving them back, but by fighting them back. This in no way implies that nothing has changed, but rather that hateful attitudes and ideas are durable and tenacious facts of our national life and always will be a part of our legacy. Of course, it is hate that has allowed AIDS to happen. Despite what you and the rest of the world now believe, this worldwide plague of AIDS is worse than ever. Truvada is not going to save the world. We must stop thinking it is and congratulating ourselves when infection rates go down in a few places. These false hopes we are trumpeting only makes our enemies ignore and dismiss what's really happening. Thinking we've been pacified, it enables them to thus hate us with increasing vigor. One has only to think of Donald Trump. Or Ronald Reagan, AIDS' first great denialist, who would never utter the word. The hate against us is thriving. So much for the power of love. We must not turn the other cheek. We must fight fire with fire. Who are our enemies specifically? And what are they still doing? I have learned that the two biggest enemies today are the same as they were from 1981 on: the National Institutes of Health and the pharmaceutical industry. The National Institutes of Health is chartered to look after the health of the American people, all the American people. Through its Division of Infectious Diseases under Dr. Anthony Fauci, we are far from being attended to with the dispatch that a contagious virus galloping through the world's population demands. Dr. Fauci is a self-serving bureaucrat who for almost 40 years has been serving too many masters who care little for us. If this were a white heterosexual disease, I guarantee it would have long since been corralled and eliminated. I long ago stopped believing the bullshit excuse that ours is a very complicated virus. We have fought Dr. Fauci from the beginning. We tried to love him for a while. He treats us as if we are his friends, just as he doesn't treat us as if we were his dying gay responsibility. It is ironic, after many years of his dumping on us, he's just discovered one of his own daughters is gay. Would that she had been there from the beginning. Despite what he and a few of our blind brothers continue to maintain, the pace of research toward a vaccine and a cure is still in the toilet. In almost 40 years, Dr. Fauci has been unable effectively to use the many hundreds of millions of dollars Congress finally allotted him. He has proved to be a terrible leader, uncreative and without imagination, a dreadful administrator, a manipulative bullshitter talking out of too many sides of his mouth. His failure has led to the murder of too many people. Too many of my activist friends have worshipped too long at the feet of the wrong savior. Too many of my friends are dead because of him. Too many of my friends are dead because of him. The pharmaceutical industry is evil incarnate. Their greed is beyond comprehension. To withhold drugs that can save lives and make them available only to the rich is, as I have said, evil. It is allowing people to die. It is murdering them. That America has allowed such behavior makes a farce of God and Christianity and democracy. I cite specifically our own experience with Truvada and its distributor, Gilead Pharmaceuticals. Gilead did not finance Truvada by itself. It was also financed by the American taxpayer via grants to the NIH, with which Gilead shares the patent. Dr. Fauci is the official NIH mouthpiece that announced to the American people that anyone with HIV should take Truvada. He then provided no help or information on how we can pay for his recommendation. Our drug that will save some money, and we have paid for it. As co-owner of the patent, Fauci can formally, legally demand that Gilead provide Truvada for free, or at least allow a cheap generic to be made and available. At the same time, Gilead is fucking us over with Truvada. They are doing the same with a number of other AIDS drugs and hepatitis meds that they are controlling. They have made many billions of dollars claiming they are saving us. A drug that costs peanuts to manufacture is dumped on each of us for tens of thousands of dollars. They are all too expensive for most patients to afford. How unchristian, how undemocratic, how selfish can you be? How does Gilead get away with this? We are all helping them to do it. They pour millions of dollars into organizations like this one to keep us quiet. By taking their money, they are enslaving us while they continue to rob us blind. Why, they are even a sponsor of the new wonderful gay series Pose, using their commercial time to show the world what wonderful things they are doing. Gilead is financing your conference. At first, I refused Paul Kawada's offer to speak here because of this. But now that a group of my activist cohorts are finally taking Gilead and Dr. Fauci to court, it occurs to me to now tell you all to milk Gilead's generosity for all you can get out of them. Ask them for grant after grant after grant to finance more of your work. Let them see that they'll be publicly shamed by turning you down. Okay, enough for now. I leave you with the one lesson I still continue to grapple with unsuccessfully at the age of 83. How painful it is to suffer from survivor's guilt over the lives we failed to save. I hope these remarks on lessons I've learned prove useful to you as we all continue our journey through the swamps of Trump. Have a good conference. Thank you.